Now the discussion is open, and I would like to start with a short question to Sean Carey, just to ask again about the role of the history which you have to get from the patient. What is the role of the history when you make the indication for frontal sinus surgery? Do you think that's a very important part, or when you talk to the patient about the symptoms, the severity, the duration of the symptoms? I mean, can you comment this very practically?
Yeah, I think the difficulty is differentiating the generalized symptomatology of sinusitis from what is specific from the frontal sinus. And really what I wanted to get over in my talk was to think carefully about that symptom of facial discomfort or headache. I think when you're looking at the totality of the symptoms, that's important in actually making the diagnosis. So you need to have those other symptoms of nasal obstruction, rhinorrhea, postnasal drip, considering making that in inflammatory sinus disease.
Okay, thank you. So any question to this topic, please? Any comments, experience? So we're just sticking in this. Okay. So if this is not the case, we go to the next speaker, to Anderson. And you showed great cases. You showed nice CT scans. I was missing a little bit the sagittal CT scans. So what is, how do you handle it? I mean, do you use it frequently? I couldn't see it in your video clips.
Yeah, I mean, of course, for every sinus procedure you're doing, you always actually have to look at the scan and see it. So, but the way the philosophy used to be is if you have someone with a large AP diameter, you used to say, so those patients, you don't have to make a much bigger opening from lateral to lateral side. But I think this is when we were thinking about the disease process as, again, an egress process where we're trying to create some way for things to come out. My thinking has changed completely in the fact that that's not what's the most important. What's most important is how big can I make this thing for inflammatory disease to get anything in there. So I'm always going to go to the border. No matter how big the AP diameter is, I'm going to try to make sure this is as large as possible. So I don't think this is as important as it is in my mind right now.
Okay, thank you. Any questions, comments, please? Please state your name and where you're from.
So my name is Dr. Janikram from India. Question to Dr. Jean. So you were talking about the modified Lothrop, right? The modification of the superior septal window to access laterally. So my question is, instead of, it's just a comment also. Did you try doing just a septal window, that is just making a horizontal incision on one side, and then just making a vertical or a horizontal incision, removing a little bit of that in-between septum, and you just have to use it as a corridor. So why such a morbid procedure of resecting the septum?
So I guess the question is...
Let me finish the question.
Yeah.
So the next important thing is that you want to go lateral. You just want to go lateral. So have you tried orbital transposition as described by Professor Castelnuovo? So if you have a combination of an orbital transposition and just a septal window where you don't resect the septum, can you achieve the same results which you have?
Yeah, you probably can. Yes, you can. And in fact, in a lot of cases where I'm removing tumors, I would do what's called a septotomy technique, elevating two big flaps, taking the cartilage out, do the surgery, and then put those flaps back. And that's something you could do. I think it's easier for me because that area is not one area that I think is going to be cosmetically or functionally that important that you could just resect it. Now, in terms of the orbital groove that you're talking about, yes, you could actually remove that if you need to go further lateral. That's one other technique you could do to get further lateral. And in fact, if I go to the contralateral side with the superior septectomy and I still cannot get to where I am going to, I will take part of the superior orbit out so that I can get laterally enough. I hope that answers your question.
Yeah.
Okay.
So I have one more question to you.
Okay, short. One more question,
Sorry.
please.
Because the results, the long-term results of a draft 2B, I think you've not, mentioned about your long-term results of how the osteal size was and what's your comment?
So I think overall my long-term results are great, but I can tell you, I can't remember the last time an endoscopic arthroscope failed for me. And I can remember that I've had a draft 2B failed before. So what I'm talking about is based on my own experience. I think the arthroscope in inflammatory disease does way better than a draft 2B. And I think you can put more medication in there. So, and I don't think the patient loses anything if you do it properly. I don't think you have issues with smell. It's a matter of getting the biggest cavity to get more medication in there without really adding too much time to the operating during the OR. Okay?
Can I make a comment there?
Yeah, please.
It's interesting, draft 2B always gets a very bad name. And that's very true because the minute you introduce the drill into the floor of the frontal sinus, your degree of stenosis significantly increases. If you can save the periosteum, you'll get a much better outcome. However, if you do use mucosal preservation and flaps, as our paper with Philippe Haumann showed, that we drop our stenosis rates of draft 2B, irrespective of pathology, down to 6 to 8%. And that probably concurs with the stenosis rates in bigger literatures on draft 3 operations. So it's really a question of using the mucosa with the periosteum intact. You do the drilling, and then you cover up the periosteum, and you can reduce your draft 2B stenosis rates. One of the concerns I have is why are we sacrificing a good side to treat the bad side? Now, I can understand sometimes for access it's essential, but if we still have techniques that are still successful, I think we shouldn't bury them. We should just see why they're happening. And we use mucosal flaps all the time in draft 3s, 2Bs, and that significantly reduces the stenosis rates.
Okay. When we're talking about draft type 2 approach, we are talking, according to the new EFAC paper by Peter Wormold, about as well the extent of frontal sinus surgery, and they differentiated the draft type 2B to grade 4 and 5, and this means you take a bit of the internal beak or you take the entire internal beak on one side, and I think this is influencing the result as well, and it's depending on the anatomy as well on the pathology. So we are going a little bit more to be differentiated, and this is influencing the restenosis rate as well. So are there more comments to this topic? Yeah, please. Now we are ready by Anshul Summers' talk, yeah, about
Oh, I'm talking about the Dr. Beckert lecture. Can I ask about this?
Which one?
Dr. Beckert?
Yeah, it's the last one, okay? Yeah. Let's be in row, okay? So we finished now Anderson, and now we're coming to Anshul Summers' talk. Any question for this? Okay, thank you. And if not, now we are at Klaus Bachers, and now please.
I told you.
To keep you a little bit,
Sure, that's okay, thanks. Dr. Beckert, could you talk more specifically about the technique of how you do this rebooting, especially about the maxillary sinus, which often harbors a lot of the mucosal disease, and the problem comes from there. Of course, the frontal is a big issue. How do you preserve the inferior turbinates, but still take the whole mucosa from the maxillary, or you didn't really mean to do that also? What is the, how do you do it, actually?
It's a, it's a bit laborious, I have to admit that, but it's a question of the instruments you have available, and there are smaller instruments. There is this, we call it Heuwieser. I don't know whether that's the official name.
Yeah, no, Heuwieser, Flamingo.
Flamingo. So yeah. What you need is all sorts of bended instruments. You need to do that. I do that stepwise. So the first part I do with a 30-degree optic, and then I go to the 70-degree optic and go even to catch the rest. And this is sometimes a little bit laborious, I have to tell you. I think the instruments will develop over time to even better instruments. There are also shavers that you can turn around more than 90 degrees in the meanwhile. So there are possibilities, but it is laborious. And very often, if you catch the mucosa on the right angle, you can strip it off a bit. It's not perfect, but it helps you to get speeding up. Honestly, I need for these surgeries sometimes 3 or more hours.
Yeah.
And that's, I mean, otherwise for a complete FES, 20 minutes. But we are here really in a laborious state if you do a full FES, a full reboot.
When you look at Peter Wormal's book and how he described how to approach the maxillary sinus, I mean, you can use the Trefine technique, the transfacial one. I mean, if there's an indication, of course, you can do it. I mean, many of my cases, I can handle it different, but maybe there's an indication to do it.
I mean, there's still this pre-sacral axis, which I try to avoid, but in 1 or 2 cases, you also need to do that, to really look into that area. But I try to work with optics, 70 degree, and the instruments to really go around the corner.
But the question is very important because about how to handle the red and the green line. And I was wondering, because doing a draft type 3 approach, usually I take part of the middle turbinate until the level of the frontal recess to get access, and then I touch already the middle turbinate. So you leave it intact?
I try to leave it as much as possible, but that doesn't mean that from the cranial part of the middle turbinate we also take some away to get a nice access to the frontal sinus. Yes, but I really believe, and I've never been disappointed by polyps coming back from that tissue. Actually, that's not the issue.
Okay, one last question, practically to Klaus. How do you measure your outcome to know which patient benefits from the biologicals? Can you tell us? Can you give us a very simple, very clear answer that we go home and say, well, I understood it, or is it still too complex?
It is still complex. There are no good biomarkers specifically now available, but the future will bring them. What do I do at the moment? First, I still go for phenotyping. That means, is that patient an asthma patient? If that asthma was developed when he was 5, has nothing to do with the polyps. But if it's developed, we call it a late onset asthma after he was 16 or just 5 years before the polyps, then you can be 99.9% sure that this is type 2. You don't need anything anymore. But otherwise, look at the eosinophils above 200 is a good sign. The higher, the better. And then also this predicts how good your biologics will work. We talk about that this afternoon. Look at the IgE. The total IgE is above 150, and you have a so-called polyclonal picture. That means you have allergies to different, you don't measure hundreds, but more than 5 specific inhalant allergens. That is a very good sign. We measure Staph aureus enterotoxin IgE very clearly linked to polyclonality. If you have these signs, you're absolutely sure. You might miss some patients who are type 2 and you cannot find it. Okay, fine, then you have to learn for the future.
Okay.
But that's the best we can do at the moment.
Claude, thank you very much. I thank every of the speakers for their contribution to this session. Thank you for coming and enjoy the Congress.